Neurology quiz number 44. What is stiff person syndrome or SPS? Stiff person syndrome is a rare autoimmune disorder causing progressive muscle stiffness, rigidity, and spasm of the axial muscles. It may also occur as a paraneoplastic syndrome. Most cases occur between the ages of 20 and 50. It is more common in women. Typically, it causes excessive muscle stiffness and rigidity of the lumbar, trunk, and proximal muscles due to sustained contractions of the agonist and antagonist muscles. This is insidious in onset and progressive, leading to difficulty walking, falls, and interference with ADL such as getting in and out of bed, arising from a chair or dressing. Patients may develop kyphosis or lordosis. There are superimposed muscle spasms precipitated by sudden movement, noise, or emotional stress. Spasms are painful and can be forceful enough to cause fractures. Examination during the spasm reveals tight and boat-like muscles. Anxiety and depression may occur as a reaction to the physical disability. Patients with paraneoplastic SPS may have symptoms indicating underlying malignancy such as anorexia and weight loss. Partial SPS may be confined to one limb, usually a leg, and is termed the stiff leg syndrome. SPS is considered an autoimmune disease. GAD65 antibodies or antibodies to glutamic acid decarboxylase in high titers are found in 60 to 80% of patients. GAD is a pyridoxal 5-phosphate dependent enzyme and the rate limiting step in the synthesis of GABA. Antibodies are found in the blood and CSF, and CSF also shows oligoclonal bands. GAD65 antibodies are also found in type 1 diabetes mellitus, and 30% of SPS patients have type 1 diabetes mellitus, but only 0.01% of patients with type 1 diabetes mellitus have SPS. Other autoimmune conditions associated with SPS include thyroiditis, vitiligo, pernicious anemia, and myasthenia gravis. The antibodies lower GABA levels in the CNS, causing loss of neural inhibition of skeletal muscles and excessive muscle contractions. EMG in SPS shows continuous motor activity in agonist and antagonist muscles, which is decreased or abolished by intravenous diazepam in sleep. Paraneoplastic SPS occurs in association with lung and breast cancer as well as Hodgkin's lymphoma. This is associated with anti-amphiphysin antibodies. Treatment can be symptomatic, and this includes benzodiazepines, which are the mainstay of treatment. Diazepam or clonazepam are common initial therapies. Diazepam is started in a dose of 5 mg 3 to 4 times a day and slowly titrated upwards. Antispasticity agents. If response to benzodiazepines is unsatisfactory, oral baclofen is given starting at 10 mg 2 to 3 times a day and titrating upwards. Intrathecal baclofen may also be used. Tizanidine and dantrolene are other alternatives. Botulinum toxin can be used to target the most painful regions. Other agents tried include gabapentin, tiagabine, Depakote, Keppra, and carbamazepine. The other form of treatment is immunomodulatory treatment. Intravenous immunoglobulin is used as second-line treatment when symptomatic treatment is ineffective. It is usually given monthly in doses of 2 grams per kilogram. Alternatives if IVIG is ineffective include plasma exchange IV steroids and rituximab.